Okay, Purva, shall I start? Okay, good evening to all of you. I will start with a short case first. Not that short case, still it's a relatively short case. Okay, what is happening? Okay. Can you see my slide? Is my screen seen? Hello?
Sir.
Can be seen now?
You can see, sir.
Okay, right, we'll start. This is a story of a 13-year-old female. She was noticed to have defective vision since childhood. Her vision is better on tilting the head to the right side. That is told by her mother. No history of any diplopia. Now, in short, defective vision since childhood, and her vision was thought to be better on tilting the head to the right side. Now, this is the position of the head of the patient, tilted to the right side. This is the position of the eyes and eyelids. Palpebral is narrower on the left side and appears sunken into the orbit. Now, this is the ocular movements. Ask you to the right side now. Ask you to the left side. Again, right side. Again, left side. Then down. Up. Up. Down. Again, look into the left side now. Right. Down.
Very good.
Okay. Any thoughts about the findings in this patient?
Sir, patient has bilateral adduction restriction, sir.
No, only abduction restriction or adduction restriction also?
Sir,
I will show the video.
Yes, sir.
Yeah, I'll show the video once again. Okay. Eyes are not going to either side. Left eye is not abducting, right eye is not abducting. Same on the right side. Right side abduction is incomplete, left adduction is incomplete. Downward movement is okay, but left eye is slightly up. Upward movement is relatively okay. Anyway, since it's a tough case, I will show the freeze frames, snapshot so that you can identify the movement easier.
Very good.
Okay, the findings were restriction of abduction and adduction bilaterally. Look into the right side. Right eye abduction is slightly more than the adduction of the left eye. Restriction of the depression of the left eye. Left eye is higher compared to the right. I will show the snapshot. Now let us analyze the ocular movement first. This is the first one. Patient is now looking to the right side. Now patient is looking to the left side. So what is your impression now? Take only one part of the ocular movement at a time. Forget the vertical movements for the time being.
Sir, was it maneuverable, sir?
Okay, that will come to that. So what do you observe here? He is unable to?
She's not able to adduct and abduct, but adduction is more impaired than abduction.
Correct. Agreed. So in fact, more impaired than the abduction, but there seems to be bilateral restriction of movement. Okay, both eyes are not moving fully to the one side, either right side as well as left side. One may be incomplete, agreed, but both eyes are not either adducting or abducting. So it's got a right-sided, is it a right-sided gaze palsy, bilateral gaze palsy, or individual muscle paralysis? Okay, now patient is looking to the right side. Now question is it bilateral gaze palsy or weakness of both lateral and medial rectus? I will sort out the issue now. Is it a gaze palsy or individual muscle paralysis? What will you like to do?
So, Manoj,
Individual muscle paralysis.
Moments, sir. Individual moments.
Pardon? What do you want? I did not hear, please.
Individual moments, sir. You have to close one eye and
No, that cannot differentiate whether it's a gaze palsy or extraocular movements. Because even gaze palsy, if you close one eye, the eye will not move underneath the eyelid. That is
Bird's eye
also
movements. Oculocephalic reflex.
okay. Ocular cephalic is one which you can do. But how does it help differentiate whether it's a gaze palsy or individual muscle paralysis? Suppose gaze palsy is due to the abducent nucleus involvement. Ocular cephalic will be negative. If the lesion is proximal to that, or in the PPRF, or in the frontomesencephalic path, that pathway I'll show you later on. In that case, ocular cephalic will be preserved. But if it is abducent nucleus is affected, ocular cephalic will be lost also because the vestibular fibers end in the abducent nuclear complex.
Gold
How will you-
calorie.
Cold calorie again you cannot differentiate because they're also getting connected to the abducent nucleus. Same pathway it takes for the vestibulo-ocular reflex, cold calorie test. The one thing which usually do in the bedside, what do you do? Suppose somebody has got a gaze palsy, say lateral gaze palsy, differentiate from lateral medial rectus. What do you do in the bedside?
it's a diplopia on looking near and looking far.
Okay. That again, okay, diplopia is, gaze palsy should not put it in diplopia, agreed. But you can have some disconjugation due to some other associated individual muscle weakness or due to skew deviation, etc. can put it in diplopia.
Cover
But
and
we
cover
want,
test.
pardon?
Cover and cover test, sir.
No, again, that will not help, no? We want to show that this muscle is due to a supranuclear or a upper motor neuron involvement and not a lower motor involvement. Upper motor involvement palsy is the gaze palsy. So you make the muscle contract by some other means. If he is able to make contract by some other means, it is
Bell's phenomenon. Bell's phenomenon. Convergence.
best phenomenon for upward movement, no?
Convergence.
Convergence, very good. It's as simple as that, convergence test. So so gaze palsy means the adduction is also not moving, no? So if you make the convergence is present, that means it is not an individual medial rectus paralysis. It has to be a gaze palsy. So convergence test. And see the convergence test now.
ഇനി മൂക്കിന്റെ അറ്റത്തോട്ട് നോക്ക്. മൂക്കിന്റെ
There's a
very
good
good, very good.
convergence.
ഇനി മുകളിലോട്ട് നോക്കിക്കേ.
No, I am going to do lateral gaze
ഇനി
once
മൂക്കിന്റെ
again to
അറ്റത്തോട്ട്
find out
നോക്ക്.
whether
ഇനി
it
നോക്ക്.
is no convergence is
മൂക്കിന്റെ
good.
അറ്റത്തോട്ട് മതി.
You ask her to look to right and left.
നോക്ക്.
See, there is no adduction.
വലത്തോട്ട് നോക്ക്.
Again, no adduction either side.
ഇടത്തോട്ട്
So the
വലത്തോട്ട്.
adduction movement is much
ഇങ്ങനെ
more
പിടിച്ചോ.
during convergence
ഒരു
than
മിനിറ്റ്.
the lateral movement.
ഈ ലൈറ്റിൽ തന്നെ ക്യാമറയിൽ തന്നെ നോക്ക്.
So its convergence is intact. So what does it mean?
Gaze palsy, sir.
Yeah, it's a gaze palsy and not due to the individual muscle paralysis. Whether patient could associate a lateral rectus involvement due to element, we cannot say. But as it stands now, it's not a pure element paralysis. Most likely, it's a gaze palsy. Okay. Now, my next question. Where is the site of lesion for the lateral gaze palsy? Is it in the abducent nucleus or is it the PPRF or in the frontomesencephalic path?
PPRF, sir.
PPRF, right? Correct. Why PPRF? Why not abducent nucleus complex?
So abducent nucleus complex comes under elements, sir. PPRF
No.
comes
No, the abducent nucleus, previously, when we were studying, when we say abducent nucleus, it is meant to supply sixth nerve. No, we could abducent nucleus actually contains interneurons which cross to the opposite side through MLF and supply the medial rectus. So abducent nuclear complex itself can produce a gaze palsy. So what will you do? What other tests to do? So let's take what is the PPRF, abducent nuclear complex, or the quantum missing cephalic pathway? What bedside test will you do? Oculocephalic reflex. Here oculocephalic is going to help us. So do the oculocephalic reflex.
മോള് കേട്ടോ അങ്ങോട്ട് കണ്ണ് മനക്ക്
It is
ക്യാമറ
not
തന്നെ നോക്ക്
overcome by
ക്യാമറ തന്നെ
oculocephalic,
നോക്കണേ
still remains stationary. That means the BOR is also
അടുത്തോട്ട് തന്നെ
affected.
ചലിക്കണം.
So oculic reflex is absent. What does it mean? It means that the lesion is in the gaze palsy is due to the abducent nuclear complex and not in the PPRF and not in the quantum encephalic pathway. Is it clear to you? Okay, I will show the pathway for understanding. Okay. So site of lesion abducent nucleus. Let us see the pathway. Now this is the abducent nuclear complex. You look at the abducent nucleus. It has got two parts. The darker green one is the one supplied lateral rectus through the abducent part. In the medial part contains abducent interneurons which cross to the opposite side and ascend in the MLF, supply the contralateral medial rectus. This is the pathway for horizontal movement. And the PPRF is the one which is above the abducent nucleus, which provides the excitatory burst neurons for the abducent nucleus. And the frontomesencephalic pathway from the opposite side descend and cross to the opposite side on the upper part of the pons to the PPRF and not the abducent nucleus. So it excites the PPRF excites the abducent nucleus and produces a lateral gaze movement towards the left side. So if there is a lesion here in the abducent nuclear complex, then what really have means that the lateral gaze palsy can be utilized in the abducent nucleus, can be utilized in the PPRF, or on the opposite frontomesencephalic path. Anywhere can produce a contralateral. I mean, if it is the brainstem, it is ipsilateral. If it is above the brainstem, it is in the midbrain or above that, it has to be contralateral. So this is the pathway for gaze palsy to one side. This causes the left-sided gaze palsy. Now, if there is what is the difference between how to differentiate between the three? If it's abducent nuclear complex, you get absent VOR and absent smooth pursuit along with the lateral saccadic palsy. Because all the pursuit pathways, VOR, ocular pathways, all are ending in the abducent nucleus and not in the PPRF. PPRF is only for your voluntary saccadic control. So other reflex pathways are all ending in the abducent nucleus. So abducent nucleus is a site of lesion for the gaze palsy. Other reflex movements like VOR pathways, other smooth pursuit movements, all will be affected. So that is how we differentiate between the gaze palsy due to abducent nucleus or due to the one above. On the other hand, if there is lesion, why this is because the vestibulo-ocular nucleus is connected with the abducent nucleus, not with the PPRF. And this is the pathway for your calorie test and pathway for your vestibulo-ocular reflex. On the contrary, the lesion is in the PPRF, you get the same thing as lateral gaze palsy, but VOR will be preserved and smooth pursuit also will be preserved. Okay. If the lesion is in the frontomesencephalic, exactly the same as a PPRF, only thing is that the palsy is to the opposite side. Okay, it is a lesion on the right side means it's equivalent to a left-sided PPRF lesion. You cannot differentiate a left PPRF from a right frontomesencephalic pathway lesion. Okay. Is it clear to you now how this differentiate between the gaze palsy due to the various sites of lesion?
Yes, sir.
Yeah, okay. Now we'll go to the next part. Now let us see. Now this is the horizontal palsy is settled. We know it is. Yeah, please.
If it is, how can we differentiate PPRF from frontomesencephalic, sir? Apart from the sites,
No,
we
you cannot differentiate. You cannot differentiate.
Okay.
Only thing, yeah. Because PPRF means it's ipsilateral gaze palsy. Frontal mesencephalic before crossing means it is contralateral gaze palsy. Otherwise, you can't differentiate.
Yes, sir.
In both, oculocephalic will be preserved.
Yes, sir.
Okay. Now let us see the little more tougher area now. Let's see the upward and the vertical movement. This is patient is looking up. The eye is almost parallel. You remember that the pulpopulsion is smaller on the left side. Congenitally also the pulpopulsion is smaller on this side. And this is looking down. So what is the problem now? From the video, I cut the relevant portion and showed you this vertical movement.
Skew, sir.
Okay, good. Yeah, it could be skew deviation. Agreed. What else? Any other possibility? Here, what do you observe? When the patient is looking up, the eyes are almost parallel, not much of a difference. But on looking down, there is definitely left eye is up compared to the right. That is not undoubted, no? Obviously, right eye is lower compared to the left eye. So one is skew, as you said. What else could be the problem?
Muscle weakness.
Yeah, muscle weakness. So which muscle should be weak?
It could be four muscles. Either the depressors of
right.
the
Ah,
left eye or elevate.
okay,
Yes.
depressors of the left eye or elevators of the right eye.
Right eye.
But yeah, but here, if it is an elevate, it is looking down, no? Here. So what is it? It's not asked look up. So what will happen? More likely to be depressors on the left eye. Okay. If the
Yes, sir.
elevators of the right is up, it would have been disconjugation would have been more on looking up.
Okay.
Here on the right side, disconjugation is not there.
Yes.
Yeah, so it has to be some depressors on the left eye. Correct? The primary position agreed. What he said is correct. It could be depressors of the left eye or elevators of the right eye. But here patient has to look down and you find the disconjugation, and looking up there is no disconjugation. That means it is not an elevator problem, it's a depressor problem.
Yes, sir.
Okay, right. So now let us see. The vertical
Left
escape.
oblique, sir.
Yeah. Please ask me.
So, since she is having a head tilt to the right, and there
Okay,
is
I'll come to that. I'll come to that. Okay, just we'll keep it at that time. We'll come to that. Okay, now this is the two possibility. Either a skew deviation or you said it could be a depressive weakness on the left side. Now, is it a vertical gaze pulse? You obviously know because the vertical is not, it is conjugate. So that's not a vertical gaze pulse. In that case, both eyes should be equally restricted up and down. So now I'm showing the video and the picture once again. Eyes are parallel and looking up. Left eye is up on looking down. What does that mean? It should be a weakness of one of the depressors of the left eye. That means left eye could be left inferior rectus or left superior oblique, correct? Okay?
Yes, sir. Yes, sir.
Now, which one is affected here? Is the left superior?
To tilt the head to either side.
Okay, right. But the patient came with the head tilt to the right side.
If there's a head tilt, it should be oblique.
Yeah, that means in the case of superior oblique, head tilt should have been on the right side. Why? Head tilt is to the right side. Suppose if the left inferior rectus is weak, usually oblique they produce head tilt, but recti can also produce head tilt, not alkaline middle rectus, but because all the vertical recti are also cyclovertical muscles, they can also got torsional action. Okay, so if it is inferior rectus, which should have been the head tilt?
Left side.
Yeah, correct. Because always head tilt is in the direction of action of the paralyzed muscle. The left superior oblique is affected, tilt should be up to the right side. If inferior rectus is affected, it should because inferior rectus is an extorter. So the head should have been towards the left side. Okay, you understood that point? Okay. Usually tilt is seen with oblique paralysis, but rarely can also occur with superior inferior rectus paralysis. And look at the action of the muscle, and head tilt is in the direction of action of the muscle. Superior oblique is an intortor, inferior rectus is a extortor. So the head will be in the extorted position if it is inferior rectus. It should be intorted position in the case of a superior oblique. Here it is tilted to the right side, the intorted position on the left side. That means it's a superior oblique palsy on the left side. Okay, clear? Clear now?
Yes, sir.
Yeah, okay.
This is
Now
clear.
we go to, yeah. Yes, any doubts? Any doubt, please clarify, please.
No, sir.
Okay. Initially somebody said it can be a skew deviation. So skew deviation is a good possibility where you can have a vertical disconjugation. Now, is it skew deviation or not? What is against a skew deviation?
It should be identical in all positions, sir.
Very good. That's perfectly right answer. So unlikely, because in skew, the vertical alignment would have been present even on looking up, because that vertical disconjugation should be in all directions. But she says perfectly, it should be conjugate. This is called skew, conjugate skew. Usually skew is conjugate. The vertical disconjugation present not whether looking up or looking down, looking right side, left side, all that vertical disconjugation is present. Because it is not due to the muscle paralysis. It is the vestibulocochlear, because the otolith connections, eyes are misplaced. That misplacement remains in the same in all directions of case. Here, that is not the situation. See, on looking up, if it is due to skew deviation, the left eye should have been up, even on looking up. Okay, but here it is not up. If at all, the right eye up is little more up. Okay, so it's not a skew deviation unless it's a concomitant. This is called comitant skin. There's an entity called incompetent skew that can have a difference in the vertical direction. On looking up, her left eye is not up compared to the right side. In skew, disconjugation remains the same in all directions of case. This is called the competent skew. They just take you are told. Okay, any questions? Please ask. Any doubts? Okay. No, this is opposite to one other. Some time back I showed an alternating skew. That is a different condition where you can have the vertical disconjugation may be different on the lateral two case. Forget about that's not the ordinary skew. That's a rare condition.
So in supine position, skew should disappear, sir.
Yeah, usually it should disappear because it's a graviceptive pathway is affected. Correct. So final diagnosis is congenital lateral rectus palsy and congenital. In fact, she has been having this problem from birth onwards. So that is why the mother brought it up because somebody is making fun of her. That is why she brought the child to us. Okay, that's good. That finishes the first case. Shall I go to the next case or any questions?
Can it be Mobius syndrome?
Mobius case due to the aplasia of the nuclei. There the gaze palsy will not be there. They can, as you said correctly, in many nucleus or subnucleus can be affected. Part of the nucleus can be affected, can be associated with the facial nerve involvement. And in Mobius, characteristically, the upper face is affected than the lower face. So, but usually it's actually purely element type, the place with the nuclei. Here there is a gaze palsy also. There is one syndrome called bilateral gaze palsy with progressive scoliosis. Yeah. Okay, shall I go to the next case? If no doubts, okay, right. Now, this is a long case. Now, I'll tell you about this case. It's a very interesting case, which everyone should know. This is a story of a 50-year-old man. He was seen by me in 2010. That is 15 years back. At that time, we had features of young onset Parkinson disease, predominantly on the right side at the age of he was 37 at that age. It was a tremor-dominant Parkinson disease and was put on Pacitane 2 milligram, a tablet 3 times daily, and Primipex, sorry about the spelling mistake, 0.5 milligram TDS, with which his disease was under control. This is my old prescription in 2010. Young onset TD, predominant tremor, Primipex, and 0.125, and Pacitane 1 TDS. He was seen in 4 years later, the condition remained the same. MEPD, same medication I given. I added Ciplar and Clonopil for some other things. He was stable till 2015. That means that from the 2010 to 2015, he was stable without any problem. And his condition, 2017, that is 7 years after the onset, he had worsening of the tremor and mild difficulty in walking. So what I did was increase the dose of Pacitane to 211 and amantadine was added, 110. And Primipex is continued at the same dosage, 0.5 milligram 3 times daily. In November 2019, 2 years later, it's very slowly progressive. Now 9 years later, he had worsening of the tremor and mild akinesia. That is the time when I put him on small dose of levodopa. Levodopa half 125 milligram. And the Pacitane and amantadine was continued as such. Primipex was changed to once a day dose, ER preparation 0.75 milligram. He was seen next on 2021, that is 11 years after the initial presentation. At that time again, he was remaining stable on the same dosage of levodopa, half, small dose of levodopa. Then he was seen next on 11 to February 2023, 2 years back. Since he had mild worsening of the akinesia, I increased the dose of levodopa, half tablet, thrice, instead of twice daily, increased to thrice daily. You can see the prescription, thrice daily. And I increased the Primipex to 1 milligram 3 times daily, instead of 0.5, increased to 1 milligram. Then he was seen in June 2023, 6 months later, 4 months later. Then at that time, he said for the last 1 month, he is worsening in difficulty in walking. And he complained of mild numbness of both feet. And there's no pain. So this is the examination in 2023 when I took the video of the patient. You can see no facial expression of Parkinson disease. Angles are all normal. Upper limb again, known power normal. There is no akinesia, no rigidity. No finger nose incoordination. Lower limb, there was mild rigidity of the lower limb. Power was good power. Dose flexion was good power. Power was good. Abduction adduction was also normal. Flexion was also normal. The reflexes were sluggish in the upper limb, or just 1+ in the upper limb. Normal in the upper limb. Abdominal reflex was intact. And lower limb slightly brisker compared to but elicited reflex. You can call it even normal reflex. And eject was also normally elicited. It's normally seen. Plantar is flexor or indefinite, not flexor. Sensory system was normal, but it's complete mild numbness over the left dorsum. That area was complete little numbness. There's only area is numbness is there. The upper part is normal. Vibration is normal in the upper limb. Normal also in the lower limb. He said no. Johnson's is also normal. SLR was negative. This is how he walked. He seems to have some bilateral foot drop like gait. And his thigh was a little abducted while right thigh was abducted while walking. And on turning, he has got a postal imbalance. And some episodes of freezing also comes in between when he comes. He has got some freezing there when he turns around. And got a postal imbalance for turning around. But a postal imbalance. Ask him to stand on heel and toes. He could lift up the toes, but he couldn't. Heel walking was difficult. Plantar flexion was good plantar flexion. Now to walk on heel is not fully, slightly coming down. See that, especially on the right side. But not convincing, but otherwise the power testing was normal. He could walk on toes very well. Rhombus is negative. This is again also the walking. All things are in the walking. So this is how he walked. Same day. Another day took the same admission. Second day made he walked. He has got on turning, he has got a freezing. A very funny type of walking. He's got a postal imbalance. Because I'm checking again because he has got a foot drop leg gait which I could not explain. On examination, power seems to be normal. Normal in both upper and lower limbs. Walking on heel was slightly defective, more on the right foot. DTR upper limb normal, knee jack 2+ bilaterally, ankle jack right normal, left just elicitable. Abdominal flex normal, plantar indefinite. Impaired pain only over a small area in the dorsum of the feet. Joint sense, vibration all normal in the feet. SLR negative. Gait bilateral steppage gait with the thigh going to abduction while walking. Now what is his problem now? Where do you want to localize the present problem, walking difficulty?
Is it some dystonia, sir?
Yeah, it could be dystonia, but the walking, is it, let me saw the walking, answer the walking once again. He's got a persistent, sustained posturing is not, he's got something like a foot drop gait. Is all the time the foot is walking like that, not episodically.
Some waddling is there, sir? Waddling?
Yeah, there is some tendency for waddling is also there, correct. Difficult. It is not the usual dystonia, but we see, we ask me whether it could be dystonia, possible. Any abnormal mode can be dystonia. So, What do you want me to do now?
Apraxia possible, sir. Apraxia of gait possible, sir.
Gait. Yeah. But it's more like rather than apraxia, it's a short stepped gait, no? It is not like that. Gait is a wide step only, so not short step. But you could have freezing is there. Freezing is there. That part I agree with you.
In
That can
atypical
occur.
patient,
Yeah,
patient
gait yeah. The gait difficulty and starting problem, initiation problem can be due to apraxia. Super apraxia is another cause. But what is striking is that his foot drop like gait. There is someone which make me.
that is
Cock walking, something like a cock walking.
Yeah, something like a
Cock
cock
like
walk.
gait.
Nerve conduction,
So what do you like to do?
nerve conduction studies.
Okay. So in fact, I did not know. Frankly, I did not know what is causing a problem. Because he thought it's a foot drop gait, but power was good, except for he could not walk on heel. Okay, so I did the nerve conduction studies. The motor conduction, sensory conduction was abnormal, but that cannot explain the foot drop. Motor conduction was normal. He had some numbness. Probably, maybe, I don't know whether he had diabetic or not. I think he must have developed diabetes by that time. FAO latency were also normal. So that could not explain his weakness. So snaps were okay, right? Now we'll go one by one. Can you explain his walking difficulty with the absent snaps? Of course not. You cannot
No.
explain. So what do you want? MRI.
Yes.
Which MRI? Brain or
Brain.
brain only? Okay. In fact, because it was the walking was something like an element type of walking, foot drop like walking. Whether it is and his reflexes were on the decreased side. We told it radicalopathy. They said what I thought. I was not sure. I told you I did not know the diagnosis at that time. Even now I do not know fully well. Okay, so this is the caudate vein, lumbar spine. There's my disc there. Thoracic cord. So in fact, I discussed with the radiologist, I wanted to make some lesion to explain his walking difficulty in the lower limb. Because upper limbs are all normal of this normal. As you said, the gait apraxia is a possibility, but walking was not like a gait apraxia. It's thigh going into abduction and foot drop like thing. And yes, no, okay. This is I'll show the video, the spine. There is nothing abnormal I could make out, no lesion to account for is this thing. This is the T1. This is the T2. There is mild disc there, but that obviously cannot explain that. And this is a lumbar axial. Normal. And the dorsal axial. Here something wrong there, the dorsal axial. In fact, I was asking the radiologist, there is some lesion. If I find out some lesion to explain, I could not explain. So we did a thin space T2 of the dorsal spine was taken to find an abnormality. And this sequence showed some abnormalities. I will show you. See the dorsal cord, there is a white hypernet, that is the CSF. CSF collection posteriorly compressed in the cord anterior. I'll show the snapshot later on. That is the area with the plovoid on the side. And this is another picture showing that thing. That is the area of increased CSF space. That is the area that is CSF space. And the corresponding sagittal cut, I'll show it in a zoom view later on. See, that's CSF space in this one. pressing on the cord posteriorly. I'll show that in the interest of time. This is the picture again. That is a hyperintense lesion in the Caesar space. Because it is an arachnoid web. That area, there is the cord is compressed posteriorly. He said it can produce myelopathy and all. So this is the area that's showing the Caesar space, the corresponding sagittal cut. I'll show the other one. This is this thing, and that is the area. There's an arachnoid web. So there is a CSF collection there that is pressing on the cord. Now, what do you think? Can you explain the deficit with this arachnoid web compressing the cord, dorsal cord?
Oh, sir.
No, I was not at all happy. I told him that if at all there should be some signal change inside the cord. There's something, cord is compressed, okay, but the patient has got pyramidal signs or whatever weakness or whatever it is, there should be something in the cord. Then I take again detailed cut. When there is hyperdensity in the dorsal part of the cord there, you can see the hyperdensity. Exactly the same area where the he said could be due to ischemia. That is the one, the hyperdensity in the cord, exactly opposite in that way. So, what do you think? Should we go ahead and do something with that or ignore? What is your impression? Should we go after that or think it is unrelated problem?
The signal changes are posteriorly located, but patients have motor weakness.
Correct. Okay, so see, seeing that it's CSF also. CSF is also normal. Now, this is the question in mind. Was the lesion the cord for walking difficulty? I thought it was not, because the gait is not spastic. If it will be a spasticity, it's not spastic. It is it's got thigh is going up and hip is going up. No posterior column of spinal sensitive affection, no bladder problems. I thought that spinal cord lesion cannot explain his walking difficulty. So I did not know what to do next. So he was discharged on the following medication without a proper diet. I didn't know the diagnosis. So this is the discharge diagnosis. It's an arachnoid web in thoracic region with coronary ischemic myelopathy, early Parkinson disease. This was the medication which was sent at the time of discharge. That is levodopa 125 3 times daily, Primipex 1 milligram, and Pacitane 211.
EMG was not there, sir. EMG?
EMG, I'll show that. Why EMG for?
Any early onset or early motor neuron disease?
Okay. That possibility can be kept. But there is no weakness. Only dorsiflexion was weakness. He is walking in a peculiar way. Anyway, that possibility has to be kept in mind. So he came after 1 month with a history of increasing walking difficulty. So what I increased increasing dorsal levodopa and asked him come for follow-up. I increased to levodopa 4 times a day. He came for follow-up only after 1 year. Probably must have improved, I do not know. Only after 1 year he was lost for follow-up. He came this June 25. Now he complained of further increase in walking difficulty. And he's got tremor of both feet. And severe starting trouble in walking. So this is the picture now. He developed tremor of both legs. And this is the way he walked. The freezing has increased. Is it a frontal gait disorder? Possible. Somebody was telling that possibility. Because he is worsening with, in spite of the levodopa. Then examine him in detail again. brain levels were normal, upper limbs were normal.
മാക്സിമം പിടിക്കും. ഇല്ല, പിടിച്ചുകൊണ്ടിരിക്കുക, വിടരുത്, മതി വിട്ടോ. ഇങ്ങനെ പൊക്കിക്ക. നൂത്ത് പിടിച്ചേ, തൊട്ട് മൂക്കി
There is no ataxia in the upper limb. I'll pass forward. Lower limb again examine. There is no motor weakness. Loose flexion was normal.
Brain not evaluated, sir.
Pardon?
Brain not evaluated.
Okay, I'll come to that. That's a good thought you had. Brain has to be evaluated. So reflexes were normally elicited. I think I'll just fast forward because his reflexes were plantar was indefinite as usual. Sensory findings were also same. He's unable to feel the vibrations and signals.
ആലോചിച്ചിരിക്കണേ. ഇപ്പോഴേ മുകളിലോട്ട്, താഴോട്ട്, താഴോട്ട്, ഇപ്പോഴോ മുകളിലോട്ട്, ഇപ്പോഴോ.
Now this is a he walked again. He's got tremendous walking difficulty with postural imbalance. Now it's there's a freezing in between, short step, much more short step. Occasionally he walks with a long stride. You need 2% support to walk. Turning around is tremendous problem. Yes. Any thoughts?
NPH is possible.
Yeah,
Had
that's
it.
what. Yeah, I got a because there's something like a confined predominantly to the lower lip. No, there's one possibility you have to keep in mind. Well, and by not a frontal gait disorder. Now he had no features of Parkinsonism in the face. Now upper limbs were all entirely normal, no akinesia. Lower, a tremor of both lower limbs while sitting. That is still difficult to explain. Mild increase in the tone. All power was now normal. ETR normal. Pandas indefinite. Gait, severe gait ignition failure. Episodic freezing, especially on attempting to walk and turn around. Postural imbalance with tendency to fall backwards. Foot drop leg gait in the right leg, which I could not explain. So what do you want me to do now?
My brain.
Okay. So in fact, I was not sure, again tell you, I was not sure about what's his gait problem. Again, I considered, as you all thought, whether it could be a bifrontal lesion or somebody asked for EMG. Again, I thought whether it's some kind of a peculiar motor neuron hyperactivity state. So I'm not sure. So I initiated the EMG was done along with the EMG. The EMG did not show anything. There is no motor neuron hyperactivity. Limbs are going into abnormal posture without any weakness. So that is why I consider no spontaneous activity. Motor neurons were normal. So I even considered a paraspinal is also done, whether it could be. Again, no spontaneous activity, motor neurons were all normal. This is an ovulation. So what to do next? MRI brain. Okay. What do you expect to find in the MRI brain?
Multiple infarcts, sir.
Okay. MRI brain was, yes, let us see. MRI brain, this MRI brain. Normal. Back to square one. What to do now? I investigated with whatever investigation I have in my mind.
Genetic workup, sir.
Pardon?
Genetic workup, sir. Because he's a young onset PD,
Yeah,
ignition failure.
that's a very good. In fact, I inquired about the genetic test and all. Only it's not from affordable, and there is no panel. I asked for any genetic familial or genetic PD panel. In that case, the cost should have been less. But they said that the panel itself also will be costing the same as clinical exome sequencing, 12,000 rupees. So thought I will defer. We cannot be afford that much.
Spasticity, isn't there no spasticity in lower limbs?
Spasticity, in fact, examiner spasticity is not there. But he's got the freezing is there.
A possibility of lead poisoning producing a motor neuropathy.
But his problem is that his nerve conduction was normal. There is no weakness except for the mild dorsiflexion weakness. That too only on not by my pressure in the bedside it is normal. Only in walking he is not able to dorsiflex.
Can it be a very rare variant of HSP?
Spasticity is not there. No.
Spasticity is not there, LMN is not there, so likely to be dystonia only, sir.
Yeah, it could be dystonia also. That's a possibility. But why is progressing then when that thing? But dystonia means he's got it's not only dystonia, he's got a freezing also, no? So means become more percent.
So one possibility is
Probably.
PSP PAGF variants, a postural instability gait freezing PSP variant.
Correct. That's it. But he has no eye signs, nothing. Upper limbs, facial, all normal.
And we try levodopa.
And he's on levodopa. Okay. Now this is after treatment. See the follow-up of the patient. This is 5 weeks after the treatment. His walking has become much better now. Now 5 weeks later, this is 7-8. This is on 11-8. His walking is still better than before. This is 12-8. Walking is still better. He was admitted and I was doing something in him. This is 14-8. 2 days later. Okay, it's little more better without support taken. Again, occasional freezing is there, but much less compared to the previous one. This is the last video on 16. He's walking much speedier now. And even has got mild freezing, but much better than he could do all his activities on his own. Initially, he needed 2% support to walk. So, what was the treatment given?
Stopping levodopa.
Clonazepam, sir.
You're right, sir.
No.
Orthostatic tremor, clonazepam.
No. What I did was, I reduced the dose of levodopa. See, from initial 4 tablets, I reduced to half tablet 3. So you can see my prescription. Half thrice daily. Then I reduced further to 100 and instead of 125, 110 half tablet 4 times daily. This is 110, not 25, the usual one. Then patients admitted gradually reduced the dose of levodopa and increased the dose of pramipexole and added amantadine. The last video which has shown when he was on Syndopa CR 125, half tablet 3 times daily because I wanted a long-acting preparation of this thing. So about instead of 110, 125, half 3 times. That is the dosage in which he was discharged. So what did the patient have?
Levodopa induced neuropathy.
Levodopa
Neuropathy,
induced dystonia.
Dystonia.
but it's not a dystonia.
Dystonia.
All kind of freezing also there. He's got dystonia. Now, this is called the paradoxical response to levodopa. You know what made me reduce? I'll tell you the story. What made you reduce the levodopa is I had one patient long back, 5 years back. This patient was seen in Saitra Institute. And he was on levodopa, syndrome plus, and he's telling he's not responding. Then what are you telling? He should respond. I admitted him and he gives the dose of levodopa. He is not responding at all. Gives the maximum dose, still he is telling, say, I'm not able to walk. Then I got frustrated. It's called features of Parkinson. So I got frustrated. What the hell it is? I stopped levodopa. Then let me see whether he'll improve or not. I stopped levodopa, still remained the same. Then I put him on Pramipex. It's a dopamine agonist. He improved. Parkinson is remarkably improved. So some people do improve not with levodopa, do with dopamine agonist. That is the one experience I had. Based on that experience only, I thought, why not I reduce the dose of levodopa and see his response? Because the other clue is that is absolutely no features of Parkinson's in the upper limb of the face. But why only in the lower limb? Why only in the freezing? Again, there is no rigidity in the lower limb. Only the freezing problem and the dystonic problem is there. So let us see. And then I started searching the literature. I found these two articles. Freezing, gait, and posture instability, unpredictable response to levodopa in Parkinson's disease. And this is the video you should see. This is from this particular article. I will show you. This is without overnight off after 12 hours without medication. The video of this patient I will show. This is without medication.
Ok, tá. Há 12 horas sem
Literature.
medicação. O mais rápido possível. Agora com a outra não.
Mild akinesia only.
Abrir o máximo.
Walking relatively okay. This is without
Chega
medication.
até lá ao fundo. Isso. Agora para cá. Sim. Sim. Outra vez. Devagar.
Turn around without any problem.
Para o outro lado.
Full test was negative.
Mais força. Isso. Ok.
Now this is on when the levodopa on phase.
Fechar, abrir, fechar.
Akinesia is worsened.
Para com a outra mão. Agora bater, levantar a perna e bater com o calcanhar no chão. Levantar a cadeira.
You're getting up, tends to
Yes,
fall
agora.
backward, postal imbalance on levodopa.
Ok.
And is turning around is even more problematic and tends to fall postal imbalance.
Mais rápido.
And the pull test was also positive. This is when the patient saw. Then he was given dopamine agonist, apomorphine,
Tudo bem?
stopping the levodopa. He got a good response to apomorphine.
Sentar outra vez.
Can turn around, there any problem. His walking is much smoother than when he's full test is negative. So this shows that the patient has got a worsening with levodopa but responded to dopamine agonist. So this is from that article. During the L-DOPA test, which clearly showed gait worsening in the on state, which deteriorated further in the supra-on condition, with concomitant improvement in the bradykinesia and rigidity. In the off state, besides hypokinetic gait, these symptoms were absent. In the on condition, peak drug dyskinesia emerged, which were exacerbated in the supra-on phase, but these were not disabling for the patient and not interfere in the gait and rating scales. With apomorphine test, there was improvement in the motor scores from off to on. Only in the supra on state there was emergence of slight freezing of the gait and postural instability. This is another article, as was pointed out. This is something that is more common in genetic Parkinsonism. They can show this abnormal response to levodopa. This article shows that paradoxical response to levodopa in Parkinson gene related early on Parkinson disease, dopa worsening dystonia. Here, the gait worsening is characterized by bizarre dystonic postures that affect the postural lower limb. Again, if you look at this particular patient, his dystonia was confined to the lower limb, and that too in the proximal muscles. The thigh was going into the abducted position. And something like a plantar flexed position. That is why it appears like a foot drop. But mainly in the thigh. Affecting the proximal lower limb muscles predominantly that occurred quickly within starting the dorsal levodopa. In this study, dopaminergic replacement therapy is associated with worsening dystonia, especially in the hip and pelvis, just like our patient. It appears that lower limb dystonia may be frequent in Parkinson mutations, and levodopa may exacerbate dystonic gait in rare phenotypes. There was dramatic response to anticholinergic, especially in Parkinson patients, without response to levodopa dopamine agonist. Some may show moderate response to dystonic gait amantadine. There is on-state freezing. It is clearly demonstrated that phenomenon of on-state freezing of gait PD existed, and that may occur in patients who took much lower doses of levodopa than those in the earlier reports. It's interesting that on-state freezing began about 5 years after the symptom onset and persisted over time. The phenomenology of on-state freezing seems to be different from the more common off-state freezing and gait freezing unresponsive to levodopa. The most patients had trembling in place. Our patient also got a tremor of both feet when the on phase. Unlike the more recognized gait freezing in PD, the on-state freezing appeared to be as severe with state walking as in turning. It is also associated with the freezing of repetitive hand movements in the on-medication state. So that's the story of the patient. Okay. That's a learning case, no? Any questions?
What is the explanation for this?
It's a paradoxical response. We do not know. Just like
Sir, I
showed
had
you.
one patient who was on pramipexole, but
Hmm.
after stopping pramipexole, he was much better.
Okay. That's something, yeah. There is some paradoxical response can occur to individuals. We do not know why it is occurring. The patient I had was the other way around. He worsened with the cinnamon, that is Syndopa plus, but improved with Primipex, the other patient which I had.
Okay.
He had severe Parkinsonism. In fact, he was not able to walk at all based on Syndopa plus, but changed to Primipex, he started walking.
His high stepping gait also seems to be better.
Yeah, much better. That must be the discontrol of dystonia. His hip abduction also became better. He has got freezing as well as dystonia, both worsened with increasing dose of Syndopa, levodopa. Because I was not knowing it. I was starting increasing because his gait, let us see the gait is improving or not. And he came after 1 year, then only the thing struck to me it could be due to the levodopa dose. Otherwise, I wouldn't have totally misled.
Is it a variant of dyskinesia drug induced?
No, most likely this must be a genetic Parkinson disease, as like a Parkin mutation. That is the one which shows this kind of a very bizarre response rather than ordinary Parkinson disease. But I wanted to do the genetic test, but I could not do that.
This patient
Yeah,
did not have dyskinesia, he had only dystonia.
Yeah, correct. Yes, no dyskinesia. It's got dystonia as well as freezing.
That's why I told atypical.
Yeah. Parkinsonism was a juvenile onset. It is even after 10 years, it did not worsen much.
The total duration is 17 years, sir.
15 years.
15 years.
Yeah, 2010.
So it's very much preserved even now.
Yeah.
Sir, as the disease progresses, how will be the drug management in this patient, sir?
No, maintain not the minimum dose possible to maintain his this thing. That is why I admitted him in the ward, and I showed the many videos, no, that each day I'm taking the video and ask the people and the bystander also take video to find what time it was and what time the dystonia occurs. Then slowly came down. When it came down to 110 3 times daily, he started worsening. So I made it to CR preparation after 3 times daily, and on that he is comfortable. You cannot go much low also. In that case, his Parkinson's will come. Only if you increase in the dosage, he goes into dystonia and freezing.
Any reference about DBS in such cases?
No idea. Okay,
Just
shall
like
we?
a primary freezing of gait, no? It's mainly, there is a condition like a primary freezing of gait where the Parkinson's will be minimal.
That is little different.
Like
Primary freezing of case is something like our NBH-like patient. On starting to walk, they have got a freezing. And a slow gait subsequently.
Was there any relation between the drug level, like after 1.5 hours after taking levodopa, it's getting worse, and like that any fluctuations?
No, there was no relationship. I saw, that's why I admitted him and asked the patient to record the video of the patient every 1 hour, 2 hours, asked him to make him walk about. There was no fluctuation, there's no change. He just said all the time he's walking, he has got that thing. Okay, shall we stop or should I show one more case?
One more short case, sir.
One more short case. Okay, short case. This is a 54-year-old man. It's an old case of diabetes mellitus. His complaint started as pain in the right side of the neck to the arm 1 week back. Along with this, he also noticed paresthesia of the lateral border of the forearm and right thumb and index finger. On the 3rd day, the patient noticed difficulty in elevating his right arm. In the past history, for the past 1 year, he has been having radiating pain along the whole of the right upper limb from the neck, and also noticed pain in the neck for the last 1 year aggravated by movement of the neck. This is the video of the patient. Taylor's normal. Yes, deltoid was weak on the right side. Could not elevate the deltoid. Biceps was weak on the right side. Biceps normal on the left side. Brachioradialis is weak on the right side. Left side normal. Biceps normal on the right side. Internal rotator bilaterally normal. External rotator is weak on the right, normal on the left side. Is weak on the right side. The finger extensions, wrist extensions, finger flexes, finger extensions, small muscles of the hand are all normal. There was no obvious swinging with the scapula, and the serratus anterior also appeared to be normal. Lower limb, there is mild stiffness, service normal, power was normal. Upper limb biceps, supinated triceps absent on the right side.
Slides are not visible.
Slides are not visible? Sorry.
Visible, sir. Visible.
Visible, sir.
Okay, sorry.
Very well visible.
Okay, sorry. Then I will play once again. Initially, he had weakness of the weakness. He had deltoid, biceps, and the brachioradialis, and external rotator is weak on the right side. Other muscles were normal. Hand grip is also normal. Lower limb muscle power was normal. Right biceps supinator, triceps absent. Left bicep supinator was present. That is present on the left side normally. Right side it was absent. Triceps is absent bilaterally. Mild wasting of the right triceps also there on the right side. Triceps is absent bilaterally.
That's fine.
Finger flexion was absent on the right side and left side. Knee jerk is slightly brisk or normal. Ankle jerk is normal. He is diabetic. It's just decreased on the right side. Plantar was flexor or indefinite. There is, even the combined paresthesia of the thumb and index, there was no sensory loss of thumb and index. But it seems mild decrease on the left side, on the right side. But on bringing down, he said not much of difference. Vibration is normal. Vibration is impaired in both feet. He is a diabetic. Joint sense is normal in the upper and lower. Is it correctly? He walked without any spasticity, normal walking. Examination, all scales are normal. Motor right upper limb, tone normal. Power, shoulder shrugging normal. Weakness of right deltoid, biceps brachioradialis, external rotators, right shoulder. Triceps, wrist finger flexion is normal. No scapular winging, no weakness of trapezius serratus anterior. Motor left upper limb, power all normal. DTR, right upper limb, all DTR absent. Left upper limb, biceps supinator present. Triceps finger flexion absent. Lower limb, both knee jerks well elicitable, both knee jerks ankle jerk absent. All normal except for impaired vibration of both toes. Rombox negative, gait normal, painful restriction of time. So where is the localization?
Any wasting, sir?
He had wasting of the triceps. The other no other muscles were not wasted.
The weakness is only 1 week duration.
Weakness is only 1 week duration. He had pain along with the pain. Initially, for 1 year, he had been having pain in along the right upper limb.
Most likely is a radiculopathy.
Okay, right. C5C6 radiculopathy is a good possibility. Okay.
Likely to be plexus because C7, there are various involvement of muscles which is not confined to either a root or a nerve, sir. There is patchy involvement, sir. Because C7, there is involvement of brachioradialis. Sorry, sir. And radial, there is involvement of brachioradialis, but there is no involvement of wrist extensor or finger extensor, sir.
In fact, that favors either root or a trunk, no? Because if it was a nerve involvement, brachioradial affection should have involved also the wrist extensors and the fingers. That is not affected. So this pattern actually favors an upper trunk or a C5C6 root.
Brachial neurite.
Brachial neurite is a possibility that we can consider.
That in that case you should consider two possibilities. 1 year symptom of neck pain and this thing is not.
And the other things, you have to think two possibilities you have to keep in mind. Correct. Okay. Then patient came with the MRI. This is the MRI. Significant stenosis at C4, C5, C6. I'll show the axial cut. This is CBJ, C2, C3, C4, 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 C5, okay. C5. Then C5, C6 has got a disc protrusion on the left side and it's more prominent on the C6 on the right, bilaterally more on the left side and C6 on the central area. Then C6, C7 more bilaterally more on the right side. This is the one. So what do you want to do?
Error condition.
Nerve conduction. Okay, nerve conduction was done. Essentially normal conduction. That also favors radiculopathy. Snaps are normal. What will you do?
Treat conservatively for the time being.
Okay.
So significant weakness.
Correct.
Which the maximum affection in the MRI is in the C7 root on the right side.
Right.
But he has got a abduction weakness. That is the maximum deficit, motor deficit is having.
Right. Exactly. So that's the point. See. So what will you do now? A patient consulted orthopedic surgery. That is why he came out to us. He has got a neurologic hematrophy. The reason I'll tell you, he has got a significant deltoid, even just 2 power of the deltoid. And biceps and other things are all 3 power. And other muscles, see, triceps are all, even though there is wasted, that may be due to old radiculopathy, power is good power of the triceps. And all of the distal muscles were all C7 root were all normal. So the findings are confined to upper trunk or C5, C6. So I did such a significant weakness and that there is no weakness of the serratus or rhomboidus. So there is a relative point, agreed, that's a point favoring a plexus involvement. More importantly, he has got acute weakness. See, whatever you are seeing in the MRI is a chronic one, chronic degenerative spine disease, disc disease. Why should put is an acute prolapse, acute weakness now for 1 week pain? Secondly, more importantly, as I was telling, his disc is got obtrusions mainly in the C6, C7 and C5, C6. But his root affected is C5. The corresponding root should be lower down. That is why it should have been C7 or C8 should be affected more. Here it is a C5, C6. And moreover, in the even C5, C6, deltoid is seldom affected in the case of a disc prolapse due to C5, C6. They usually get either biceps weakness or triceps weakness or a biceps and macroiliac weakness. So he was put on IV steroid and improved. He had a severe pain. He was initially, after admission, also is complaining of severe pain. And the pain was only for last 1 week. He had initially radiating pain, but he's not bothered about that pain. His pain, severe pain was now.
Is there any tinner sign positive over the brachial plexus? Okay.
There's no dorsal tenderness or nothing was there. So neurologic hematrophy can have sometimes severe pain or sometimes without any pain at all.
Other side also can involve sometimes.
Pardon?
Other side also can get involved.
Yeah, definitely. Even if you look one side, if you examine the other side, you might finding the other side also which is asymptomatic. You may not complain unless you look for, you may find external rotator's weakness on the other side. As Montessori are telling, that's also a side I will keep in mind. If you find other side, that's an important point favoring a brachial neuritis. Then
Brachial nerve conduction study was also normal. Deltoid pickup and
that you will not get now because many a time if you do conduction brachial neuritis, they are going to be normal. Because the affection is distal to that now. In fact, you are stimulating the nerve distal to that. It's a demyelinating block, it all will be normal.
Okay.
And axonal changes only appear later on, not immediately.
The diabetes is a predisposing condition also. It's a diabetic.
It's a diabetic, but that we can't say it's a predisposing factor because many a time this is seen without diabetes.
Okay.
Okay, shall we close? Any doubts in this case? Okay.
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 Thank you, sir.
See you.
Thank you, sir. Good night, sir.
Thank you. Good
Thank you,
night.
sir.
Good
Good
night.
night, sir. Good night, sir.
Good night, sir. Good night.
Good night. Good night. Good night.